It's a pleasure to be here. Thank you so much for inviting me to VE and AME and making this workshop possible. Today I'll be delighted to talk to you about the ethics behind the use of AI in medicine, future considerations. First up, I'd just like to thank a lot of my colleagues at the center who put a lot of hard work and help into the ideation of a lot of what I'll be talking about today, as well as our AI ethics working group members comprised of clinician scientists, academics, and industry leaders in Singapore. So I guess first up, just a little bit about our approach to AI ethics, which we like to think of as a bottom-up approach. So this approach intends to shift away from principles first or overarching framework approaches to a use case-driven approach that drives challenges from the ground up in non-ideal practical settings. We work very closely with clinician research teams who are closer to what's happening on the ground and might have insights and perspectives that we don't always have access to. And by doing this, we try to avoid cherry-picking principles or the shoehorning problem of force-fitting principles onto challenges where they don't always match. Instead, we intend to respond to the specifics and particularities of a case. So today I'll talk about three main topics. The first is meaningful bias and whether it is ever justifiable to implement a biased AI. The second is human involvement, or what many of you will be familiar with as human in the loop. And the third is the risks of risk prediction. How much risk is reasonable in an already risky world? So, most of these topics are motivated by what is known as the AI chasm, so the gap between the development of a robust algorithm and its clinically meaningful application. Despite the promise of AI, very few algorithms actually make it to the point of care. So the following case studies are ways for us to think about how we can get through this translational aspect of the AI chasm. Meaningful bias. Is it ever justifiable to implement a biased AI? Our broad claim is that there is an almost wholly decisive reason not to implement any AI that is more biased than current clinical care models. But are there counterexamples? Our case study addressing this ethical challenge comes from 2017, when a team from Duke NUS in Singapore developed a deep learning system to detect the progression of diabetic retinopathy and glaucoma, referred to as DLSDR. As we all know, diabetes is a chronic disease. It affects 1 in 10 adults worldwide. When poorly managed, patients may suffer diabetic retinopathy, which can lead to blindness. DLSDR helps to assess retinal scans by flagging when a certain progression of the disease is reached. Then, radiologists can decide whether to refer the patient to an ophthalmologist. But the algorithm was found to underdiagnose Malays more than it underdiagnoses other affected groups, such as Chinese and Indian patients. This is bad. Underdiagnosis means the disease can go untreated and possibly progress. So avoiding underdiagnosis is better than avoiding overdiagnosis, where an ophthalmologist still has the opportunity to confirm or deny the diagnosis. However, Malays were already being underdiagnosed before the implementation of DLSDR in the social context. In an unbiased system, we would expect the rates of referable diabetic retinopathy to roughly track the proportion of diabetics who are Malay, weighted by the degree average of disease control. While more than 20% of diabetics are Malay, only 7.3 of those referred are Malay. This suggests some sort of background bias. This could stem from various factors, including personal, conscious or unconscious bias, on the part of the physicians or graders, disparities in patient participation in screening, distrust of the medical establishment, workplace discrimination, poverty, religious fatalism, lack of education, cultural norms, and even personal choice. Implementing DLSDR into this social context would likely result in more referrals across all affected groups when compared with unaided clinical judgment. This is due to the boost in efficiency that the system provides. However, it could also widen the disparity between Malays and non-Malay groups. Unfortunately, we know that systemic bias is already present in the health system. Thus, any medical AI is more likely than not to have lingering bias due to biases in the training data. And this may reflect other social inequalities. In our case, there are both discriminatory and non-discriminatory factors that contribute to the disparity between Malays and non-Malay groups. Nonetheless, most, if not all of these causes, remain untouched by the implementation of DLSDR. Implementing DLSDR would increase referral rates across groups, boost efficiency, and reduce costs. All of this putting utility and equity at odds. In difficult situations like these, we argue it's justifiable to implement a bias tool where, one, its introduction reduces the influence of biases, and or two, where the utility gained is significant enough and shared across groups. Since DLSDR would result in significant benefits in well-being as well as wider social benefits through the prevention of job loss and disability, the implementation of DLSDR, we argue, is ethically justifiable. Next, I'd like to talk about human involvement, how and to what extent. This will be centered around what many of you will know as human in the loop, or keeping a level of human oversight throughout the use of any AI tool rather than full automation. Our broad claim is that keeping humans in the loop has been equated with good ethical practice in some circles, and for good reason. As the prospect for automation becomes more realistic in many settings, are there cases in which we can challenge and or redefine the loop? Our case study refers to the NUS-NUH Medical School's development of Spine AI, an AI model narrowing in on an MRI scan of the spine to diagnose lumbar spinal stenosis, or LSS. LSS is a potentially debilitating condition affecting many adults globally and having a significant impact on livelihood. Spine AI draws boxes around the affected areas of the spine and provides measurements. A radiologist can then double-check and move forward with a diagnosis. Spine AI is considered a black box model because the ultimate criteria for determining the grading is not clear to the grader. However, we like to say it's a species of interpretable as well, because it marks the relevant region, allowing for better double-checking, and there was no trouble understanding it on the part of the radiologist, and also no resistance to implementing it because of this understanding. Therefore, the biggest ethical challenge is considering the implications of kicking the humans out of the loop, and in this case, the radiologist reading the scan. As many of you know, keeping humans in the loop has often been equated with good ethical practice, and in many cases it is. However, we should be careful to evaluate this on a case-by-case basis. Spine AI was shown to produce significant benefits, including being more consistent and accurate, making better clinical decision-making and improving patient outcomes, improving the accuracy of inexperienced readers, improve turnaround time, and reduce costs. Each of these metrics were also demonstrated at an impressive scale, with reporting time reduced by 70%, which could result in up to 780,000 SGD of savings per year. Spine AI also avoids many of the common risks we see with new health AI. First, the training data was racially heterogeneous, suggesting we can trust the validity of its conclusions. It's transparent, and there are pre- and post-scan scan consultations with a clinician. Should there be a need for surgery, this would be decided by a surgeon. As for the costs, the overall risk to the patient is low. It is only an image reading tool, and LSS is not life-threatening. In low-resource settings, the real trade-off could be the difference between a patient's scan being read by a tool or not being read at all. So we argue that it is ethically justifiable to kick humans out of the loop when the technology is as effective or better than a human at a given task. 2, the risk to patients or any humans involved is low in the event of an error. And 3, the well-being that is gained by the speed, accuracy, and cost efficiency of automation is high. So in the case of Spine AI, kicking humans out of the loop would be justified. Finally, the risks of risk prediction in triage. Our broad claim is that AI risk should be ethically evaluated similar to other medical interventions and processes appropriate to the level of risk they pose. The assessment of risk needs to be calibrated to the levels of risk that are acceptable for translation of new tech or other interventions into clinical contexts, and not necessarily treated as an exceptional kind of risk. It is well known that emergency departments globally face significant challenges due to overcrowding and delays, which can negatively affect a patient's care. Triaging processes to assess risk acuity of incoming patients include an assessment of various factors, including vital signs, mental status, and the subjective judgment of the healthcare professionals, who should be attentive to patient disorientation, pain, or distress. In Singapore, all emergency departments currently use the national triage system known as the Patient Acuity Category Scale, or PACS. This trains nurses to prioritize patients requiring immediate attention down to non-emergency cases on a scale of 1 to 4. Duke NUS recently developed a new interpretable AI model to predict the profile of the 30-day mortality risk at admission. The tool adopts a machine learning model to produce a new triage outcome score known as the Score for Emergency Risk Prediction, or SERP. Unlike PACS, SERP is not a severity classification index and does not instigate or determine a care pathway. Using local electronic health records, SERP was validated during 2 retrospective studies, one in Singapore and one in Korea. In both, SERP had better prediction scores for mortality than existing commonly applied clinical scores, including PACS. However, it is currently unknown whether SERP can improve outcomes in actual clinical practice, as further prospective data is needed to validate its real-world capabilities. In order to implement SERP, an RCT, or randomized control trial, would usually be the route to validate its effectiveness and safety. However, we talked about this in your talk, Yuro, thank you. An RCT may not always be feasible due to the way clinical judgment interacts with the triage process, complicating the blind arm of the trial. Thus, other implementation strategies are being considered, such as ongoing evaluation type studies that account for all variables. The research team has proposed the following implementation strategy. First, a 6-month prospective and non-interventional silent trial, whereby SERP and PACS would run alongside one another, but the SERP score would remain unknown to the triage nurse and not used in practice. Then, if the prospective data is successful and aligns with the retrospective data, then PACS would be replaced by a new model called PAC+. PAC+ would employ PACS score as normal and use the SERP score to fine-tune the PACS score in practice. Let's start with the silent trial. On the one hand, we know that relying on retrospective data and accuracy alone does not allow us to understand an AI's real-world capabilities. But is a silent trial necessary? While the silent trial will give us much of the prospective data needed to understand SERP's real-world performance, it will delay the full implementation of SERP, which has the potential to improve patient outcomes and emergency department efficiency. The silent trial also fails to account for how nurses will actually use SERP in practice. Various factors may influence how a nurse employs SERP, and we should consider if the risk posed by the AI system in this case is exceptional. The current scoring system, PACS, relies heavily on clinical judgment, which has the potential to be influenced by the nurse's level of experience, emotional responses, and environmental factors, such as distractions or noise. SERP avoids emotional responses and influenced by such environmental factors. However, that is not to say that emotional responses aren't essential and cannot be incredibly helpful in many situations, because the care and compassion of a nurse who evaluates a situation holistically is invaluable. But it is to say that the AI avoiding these influences does not introduce a new, riskier factor. Second is the risk of technology bias, where a healthcare professional may be wary of new tech or not trust it, as well as automation bias, where a healthcare professional might trust the new AI too much and forget their own clinical judgment. Each form of bias can potentially lead to misusing the tool and thus manipulate prospective data. Finally is interpretability, which some argue is absolutely essential in medicine. SERP is interpretable. It uses 6 variables with a points-based algorithm to generate a raw risk score. Nurses can clearly see how it comes to its conclusions, which enables them to use the tool correctly. Because of all of these factors, the silent trial is needed to ensure we understand SERP's raw risk score aligns with retrospective data before we introduce the risks involved in how nurses will use SERP in practice. Now we can move on to evaluating the PAC+ model. As 26 is the optimal threshold that maximizes the sensitivity and specificity for predicting 30-day mortality, nurses would be able to fine-tune the PAC score as follows. The PAC score would be applied as normal. Then, if the SERP score is less than 26, the patient will be down triaged by 1 PAC score. If the SERP score is equal to or greater than 26, the patient will be up triaged by 1 PAC score. The final decision to fine-tune will still be one determined by clinical judgment. This bidirectional approach allows the PAC score to be calculated and applied as normal, and the SERP score to be calculated and given to the healthcare professional as additional information for adjusting the appropriate triage score. Using SERP in practice risks false negatives and false positives. False negatives happens where SERP underestimates mortality risk, which could lead to worse patient outcomes by failing to attenuate risk of death or serious harm correctly. False positives could lead to the unnecessary use of limited medical resources, as well as put those who are deprioritized at risk. Let's look at the benefits and risks. Further retrospective analysis shows that this bidirectional fine-tuning approach has high specificity with a large decrease in false positives as compared to PACS, and no significant decrease in sensitivity. As for the risks, implementing a raw risk SERP score as full replacement to PACS is a major deviation from established clinical care, imposing new risks on patients due to the lack of calibrated workflows to triage score. As the risks of deviating too much from current successful workflows puts too much risk on the patient, this fine-tuning approach is needed. So assuming further observational data aligns with the retrospective analysis, the PAC+ approach is supported. Now that we understand the case, we can see where certain principles may be useful in the implementation strategy. While dominant research ethics paradigms make a sharp distinction between research and practice, LHS offers a way to integrate them. LHS moves beyond implementation frameworks and into the ethical realm, suggesting the 6 main principles you see here. And that's all I have for you today. If you'd like to learn more about the work we're doing and a more detailed analysis of what I spoke about today, please head to our website here. And thank you.